Welcome to Bookfulness. This is number 28 of our deep dive series focusing on clinically oriented anatomy.
That's right. We've been working our way down the lower limb. Last time we tackled the anterior and medial thigh compartments. Lots of important stuff there for hip flexion and adduction.
Yeah, that really sets us up nicely for today. We're shifting our focus, moving posteriorly to what you might call the engine room, the gluteal and posterior thigh regions.
A really crucial area.
We're drawing from Chapter 7 in the 8th edition, covering pages 1133 right through to 1164 in the original text.
And our goal today really is to get a solid functional grip on these muscles, the ones doing hip extension, stabilization, and critically trace those major nerves and vessels running through, especially the famous sciatic nerve.
Absolutely. It's so fundamental for how we move, how we walk. So let's get into it.
Mhm.
Okay, let's start with the basics, defining the space. The gluteal region, the buttocks, the hip area. How does the book outline its borders?
Yeah, the boundaries are quite clear, which is important clinically. So superiorly, you've got the iliac crest, that ridge of bone you can feel at the top of your hip.
Right.
Medially, it's the intergluteal cleft, also called the natal cleft.
Okay.
And then inferiorly, you have that horizontal skin crease, the gluteal fold.
And that fold is pretty significant, isn't it? It's the dividing line.
Exactly. It marks the separation between the gluteal region proper and the back of the thigh, the posterior femoral region. Tells you where one set of muscles kind of ends and the next begins.
So within this region, sitting over the pelvic girdle, we find the superficial muscles. The text lists 4 main ones.
That's right. The big players superficially are the gluteus maximus, gluteus medius, gluteus minimus, and the tensor fasciae latae, or TFL.
Let's zero in on the gluteus maximus first. Everyone knows it's the largest muscle in the body, geometrically speaking. And the text confirms it's the strongest hip extensor we have.
No question. It's huge.
But here's the interesting part. Its function. It seems quite selective in when it actually works hard.
Yeah, that's a really key point. It's like a specialist called in for the heavy lifting. Its main actions are powerful extension and lateral rotation of the thigh.
Right.
But the text really emphasizes that it's mainly fired up only when you need significant force.
So things like pushing up from a seated position.
Exactly. Or straightening up if you've bent over. Climbing stairs, running, sprinting. Anything requiring real power to extend the hip against resistance. That's its job.
It's built for maximum force production.
Precisely. Think about the leverage needed to push your whole body weight up from a squat or lunge. That's the gluteus maximus winning its keep.
Okay, but here's the nuance that often surprises people, myself included initially. What about just walking normally on a flat surface? If it's the strongest extensor, why isn't it the primary mover then?
It really comes down to energy conservation, efficiency. During regular level walking, the movement isn't that forceful. The momentum from your leg swinging, plus the work of other muscles like the hamstrings, is usually enough to get the job done. Bringing the massive gluteus maximus into play for every step would just be, well, metabolically expensive.
So the body kind of saves it, keeps it in reserve for when the power is actually needed.
That's a great way to put it. It uses more efficient muscles, mainly the hamstrings, for the routine work of walking, and keeps the G-max ready for high-demand situations. It's biomechanically smart.
Fascinating. And we should also mention its connection to the IT band, the iliotibial tract.
Definitely. A large part of the gluteus maximus actually inserts onto that tough band of fascia running down the side of the thigh. So when it contracts, it pulls on the IT tract, which helps stabilize the femur and even the knee joint laterally. Super important when you're bearing weight on one leg.
And with a big muscle moving over bone, the greater trochanter specifically, you need protection. That brings us to bursae.
Yes, absolutely. You have several bursae around there, like the trochanteric bursa, which is quite large. These are like little fluid-filled sacs that reduce friction.
Like cushions.
Exactly. They let the muscle and its tendon glide smoothly over the bone during movement. They're constantly working, which, as we'll see later, makes them prone to irritation and inflammation bursitis.
Right. So understanding the G-max means knowing its power, its selective use, and the structures like bursae that support it.
Perfectly summarized.
Okay, let's peel back that gluteus maximus layer. Deeper down, we find the other key players in that sort of superficial to mid layer, gluteus medius and gluteus minimus. The book classifies them as abductors and medial rotators.
Yeah, technically that's what they do if you isolate them. Abduction is moving the leg out to the side. Medial rotation is turning it inwards. But their day-to-day job, their critical function, is all about stabilizing the pelvis during walking.
Pelvic stabilization. This is a really important concept, often a tricky one. Let's break it down. We walk in phases, right? Swing phase, stance phase. Where are medius and minimus most active?
They are the stars of the stance phase. Specifically, when you're standing on one leg, the single support phase. So your right foot is on the ground, your left leg is swinging through, all your weight is on that right side.
Okay, so if my weight is on my right foot and my left leg is off the ground, gravity wants to pull the left side of my pelvis down, right, make it dip.
Precisely. That's the natural tendency. And this is where the gluteus medius and minimus on the right side, the stance side, kick in powerfully.
How do they stop the dip?
Think of them attaching from the ilium, the pelvic bone, down to the greater trochanter on the femur. Since the right foot is fixed on the ground, the femur is relatively stable. So when these muscles contract, they pull the ilium down towards the stable femur on that side.
Okay.
Which effectively prevents the opposite, unsupported side of the pelvis from dropping. They act like strong guy wires, holding the pelvis level.
So their main job isn't so much lifting the leg out to the side, but preventing the other side of the hip from falling down when you lift that leg. It's counteracting gravity.
You've got it. It's absolutely crucial for a smooth, efficient gait. Without that strong contraction on the stance side, the pelvis would drop on the swing side with every step. That leads to what's called a Trendelenburg gait, or a waddling motion.
Which is why damage to the nerve supplying these muscles is so significant clinically.
Exactly. If that nerve, the superior gluteal nerve, is damaged, these muscles weaken or fail. The unsupported hip drops, that's a positive Trendelenburg sign. The person then has to compensate by leaning their trunk way over towards the stance leg to try and keep their balance. It's a very characteristic sign.
And you mentioned medial rotation, too.
Yes, the anterior fibers of both medius and minimus can also help medially rotate the thigh. It helps fine-tune where your foot lands.
What about the tensor fasciae latae, the TFL? We listed it with the superficial group. Small muscle, but seems important because of that IT tract connection again.
It is. The TFL is also an abductor and medial rotator. Its main job, though, is suggested by its name. It tenses the fascia lata, that sheath covering the thigh muscles, and specifically pulls on the iliotibial tract.
Keeping things taut.
Exactly. It helps maintain tension down the lateral side of the thigh, providing stability to the hip and, importantly, the extended knee. It works synergistically with the gluteus maximus through that IT tract connection.
Okay. Now, moving even deeper still, we get to a group known as the deep lateral rotators.
Right. This is a group of smaller muscles situated underneath the gluteus medius and minimus. Their primary collective action is, as the name implies, lateral rotation of the thigh, turning the leg outwards.
And within this group, one muscle gets singled out as a key landmark, the piriformis. Why is this one muscle so important organizationally?
It's all about location, location, location. The piriformis muscle runs right through the greater sciatic foramen, which is the main exit point for structures leaving the pelvis to enter the gluteal region.
Ah, okay.
It effectively divides that foramen into two spaces, one superior to the piriformis and one inferior to it. So almost all the important nerves and blood vessels entering the buttock have to pass either above the piriformis or below it.
So if you can find the piriformis,
you can orient yourself to pretty much all the major neurovascular structures back there. It's the geographical key to the deep gluteal region.
Okay, so the piriformis is our landmark. What are the other muscles in that deep lateral rotator group?
Well, there's a functional unit sometimes called the triceps coxae. That term isn't always used, but it refers to three muscles working together: the superior gemellus, the obturator internus tendon, and the inferior gemellus.
Gemellus means twin, right?
Yes. The two small gemellus muscles basically flank the much larger tendon of the obturator internus muscle as it emerges from the pelvis. They all insert together and act as lateral rotators. They also help stabilize the femoral head in the socket, especially when the hip is flexed.
And there's another one, the quadratus femoris.
Right. Quadratus means square-shaped. It's a flat quadrilateral muscle located inferior to the gemelli and obturator internus. It runs from the ischial tuberosity, your sitting bone, across to the femur.
And its action.
Given its horizontal orientation, it's a powerful lateral rotator. It helps pull the greater trochanter posteriorly.
We should also quickly mention the obturator externus. It's sometimes grouped elsewhere, but it contributes here too.
Yeah, its origin is deep on the anterior side of the pelvis, but its tendon wraps around posteriorly underneath the hip joint to attach near the other lateral rotators on the femur. So functionally, it acts as a lateral rotator as well.
Okay, that covers the deep rotators. Now, if we move down from the gluteal region proper, we get into the posterior thigh compartment. And this area is dominated by one famous muscle group.
The hamstrings. Absolutely. They are the major occupants of the posterior thigh.
Anatomically, there are three true
That's
hamstrings.
the standard definition, yes.
Mm.
We're talking about the semitendinosus, the semimembranosus. Those are on the medial side of the posterior thigh, and the long head of the biceps femoris on the lateral side.
What's the defining feature that groups these three together? Why are they the true hamstrings?
The key is that they share a common origin point, mostly from the ischial tuberosity.
The sitting bone again?
Right. And critically, they are two joint muscles. They cross both the hip joint posteriorly and the knee joint posteriorly.
Ah, so they can act on both joints.
Exactly. This gives them their dual action. They can extend the hip, pulling the thigh backward, or they can flex the knee, bending it.
This dual action is central to their function in walking. We established earlier that the huge gluteus maximus isn't the main hip extensor in normal walking.
Right. It's the hamstrings that are doing most of that work during a regular stroll. They provide the push-off, the hip extension needed for propulsion, in a much more energy-efficient way than the G-max.
So they're the primary hip extensors for everyday low-effort walking.
Correct. That's a really critical functional point to grasp.
But then there's the paradox. The text emphasizes their most strenuous activity, the time they're most likely to get injured, isn't during extension, but during the swing phase of gait. Can you explain that?
Yeah, this is crucial for understanding hamstring injuries. It happens during the terminal swing, right before your foot hits the ground for the next step. As your leg swings forward, propelled by hip flexors and momentum, it's accelerating. Just before heel strike, the hamstrings have to contract very forcefully, but eccentrically.
Eccentric contraction. That means the muscle is contracting while it's actually getting longer.
Precisely. They are actively contracting to resist or break the forward swing of the thigh and the extension of the knee. They act like decelerators
Why do they need to brake?
to control the landing, to slow the limb down so you can place your foot accurately and relatively gently for the heel strike. If they didn't do this, your leg would just swing forward uncontrollably.
And that braking action, the eccentric load, is where the danger lies.
That's exactly it, especially during high-speed movements like sprinting. The muscle is trying to contract strongly while being forcibly lengthened by the momentum of the swinging limb. If that lengthening force is too great or too sudden, the muscle fibers tear.
So most hamstring strains happen not when pushing off, but when trying to slow down the leg swing.
Correct. It's a failure during deceleration under very high tension. This is why the text mentions stretching. Good hamstring flexibility allows the muscle to tolerate that rapid lengthening under load more effectively. If they're tight, they reach their breaking point much sooner.
Okay, we've mapped out the muscles. Now let's trace the nerves that control them. We need to go back to our landmark, the piriformis muscle. You said nerves pass either above or below it?
That's the key. Let's start superiorly. The superior gluteal nerve, its roots are L4, L5, S1 takes the high road. It exits the pelvis through the greater sciatic foramen above the piriformis.
And it supplies.
It supplies those crucial pelvic stabilizers we talked about. The gluteus medius, the gluteus minimus, and also the tensor fasciae latae, TFL.
Makes sense. Damage that nerve and your gait is immediately affected because those stabilizers lose function.
Absolutely. That direct link between nerve, muscle, and function is clear.
So logically, there must be an inferior gluteal nerve.
There is. And as you'd expect, it exits the greater sciatic foramen inferior to the piriformis. Its roots are L5, S1, S2.
And its target.
It has one main target, but it's a big one. The gluteus maximus.
Ah, the powerhouse.
Right, so if you injure the inferior gluteal nerve, you lose that powerful hip extension needed for climbing, jumping, rising from a chair. Walking on level ground might be less effective because the hamstrings can compensate to some degree, but forceful extension is gone.
Are there other significant nerves exiting below the piriformis?
Yes, there's the posterior cutaneous nerve of the thigh. Cutaneous means skin, so this is primarily sensory.
What area does it cover?
It comes from S1, S2, S3 roots and supplies sensation to the skin on the back of the thigh, all the way down to the popliteal fossa, the area behind the knee. Important for sensory feedback from that whole region.
Okay. And now, the main event, the sciatic nerve.
The big one, yes. It's formed from a large convergence of nerve roots from the sacral plexus L4, L5, S1, S2, and S3. The text correctly notes it's the largest single nerve trunk in the entire body.
Largest in diameter.
Yes, it can be up to 2 centimeters wide near its origin. It's a substantial structure.
And its path relative to the piriformis.
The most common pattern, the typical arrangement, is that the entire sciatic nerve trunk passes inferior to the piriformis muscle, alongside the inferior gluteal nerve and artery, and the posterior cutaneous nerve.
But variations exist.
They do. Sometimes the nerve splits higher up, and one part, usually the common fibular component, might pierce through the piriformis muscle belly or even pass superior to it. These variations are important clinically, as we'll discuss with piriformis syndrome.
So assuming the typical course, it emerges below piriformis and then heads down the posterior thigh.
Correct. It runs deep to the gluteus maximus, then lies on top of the deep lateral rotators we discussed earlier, and then descends deep to the long head of the biceps femoris in the thigh.
Now, you mentioned it splitting. Even though it looks like one nerve, it's functionally two nerves bundled together.
That's a crucial concept. Inside that common connective tissue sheath, there are actually two distinct nerves. The tibial nerve component, generally more medial, and the common fibular or common peroneal nerve component, usually more lateral.
And they eventually separate.
Yes, they typically diverge into two separate nerves, somewhere in the upper part of the popliteal fossa, behind the knee. But as I said, that split can happen much higher, sometimes even within the pelvis or gluteal region. Knowing this dual composition is key to understanding patterns of injury.
Speaking of injury, its location makes it vulnerable, especially with hip problems.
They're extremely vulnerable. It runs very close to the posterior aspect of the hip joint capsule. So a posterior dislocation of the hip, where the femoral head is forced backward out of the socket, or a fracture dislocation, very frequently stretches or compresses the sciatic nerve.
Which would have devastating consequences.
Absolutely. Depending on the severity, it can cause complete paralysis of the hamstrings and essentially all the muscles below the knee, leading to foot drop and major functional loss, plus significant sensory loss. Its size and location make it a major clinical concern in hip trauma.
Let's switch to the blood supply. Do the main arteries follow the same pattern as the nerves relative to the piriformis?
They do, mirroring the nerves. You have the superior gluteal artery exiting superior to the piriformis, running with the superior gluteal nerve.
And it supplies.
It branches out. A superficial branch helps supply the overlying gluteus maximus. A deeper branch dives down to supply the gluteus medius, minimus, and the TFL again, matching the nerve supply to those muscles.
Makes sense. And the inferior gluteal artery?
Exits inferior to the piriformis, alongside the inferior gluteal nerve and the sciatic nerve. It's a major supplier to the lower part of the gluteus maximus, and also sends branches to those deep lateral rotators like obturator internus and quadratus femoris. It also gives off some initial supply to the very top parts of the hamstrings.
But you mentioned earlier the hamstrings get most of their blood from elsewhere.
That's right. While the inferior gluteal helps proximally, the main workhorses for supplying the bulk of the hamstring muscles down the thigh are the perforating arteries.
Where do they come from?
They're usually branches of the profunda femoris artery, which is the deep artery of the thigh branching off the main femoral artery. They're called perforating because they literally pierce through the adductor magnus muscle to get from the medial compartment into the posterior compartment to reach the hamstrings.
So a robust supply system. This brings us to an important vascular feature mentioned in the text, the cruciate anastomosis. What is an anastomosis, first off?
And the anastomosis is basically a connection or a network between blood vessels. It's like a natural bypass route.
And the cruciate anastomosis, why cruciate?
Cruciate means cross-shaped. It describes the pattern formed by the arteries involved. It's a really important network of connections located high up in the posterior thigh, near the hip joint.
Which arteries connect here?
It's typically formed by four main contributors coming together. The inferior gluteal artery, coming down from the pelvis, branches from both the medial and lateral circumflex femoral arteries, which usually arise from the profunda femoris and wrap around the femur, and the first perforating artery coming up from the profunda femoris.
So vessels from the pelvis connecting with vessels from the thigh. Why is this connection so vital?
It provides crucial collateral circulation. Imagine if the main artery supplying the leg, the femoral artery, got blocked high up near the hip, maybe due to injury, disease, or surgery.
Blood flow to the rest of the leg would be cut off?
Potentially, yes. But the cruciate anastomosis provides an alternative route. Blood can flow from the internal iliac artery in the pelvis down through the inferior gluteal artery, cross over through this network, and then flow down into the profunda femoris system via the circumflex branches and perforators, effectively bypassing the blockage.
A built-in safety mechanism.
Exactly. It can be limb-saving. It ensures that even with a proximal blockage, the lower leg and thigh can still receive blood flow. It's a beautiful example of anatomical redundancy.
One more vessel to clarify. The internal pudendal artery. It passes through the area.
It does, but it's just passing through, really. It exits the pelvis via the greater sciatic foramen, often near the sciatic nerve, but then it quickly loops back around and enters the perineum through the lesser sciatic foramen.
So it doesn't supply the gluteal muscles or hamstrings.
No. Its territory is the perineum, the external genitalia, and associated structures. You just need to be aware it travels briefly through the gluteal space en route to its final destination.
Okay, let's bring this down to the surface. How can we use surface landmarks to visualize these deep structures, particularly for clinical practice?
Palpation is key. You can easily feel the bony landmarks like the iliac crest superiorly, the greater trochanter laterally, and the ischial tuberosity inferiorly when seated.
And locating the sciatic nerve.
You can approximate its course. It runs roughly midway between the greater trochanter and the ischial tuberosity as it emerges from under the piriformis, then descends deep down the midline of the posterior thigh. But remember, it's deep to the G-max and hamstrings.
Which leads directly to the practical point about intramuscular injections. Why is location so critical here?
Because the sciatic nerve is so large and runs right through the main bulk of the buttock region, sticking a needle in the wrong place can directly damage the nerve, which is catastrophic. Iatrogenic injury caused by medical treatment is a real risk.
So where is the safe zone?
The universally accepted safe zone is the superior lateral quadrant of the buttock. Imagine dividing the buttock into 4 quadrants with a vertical line down from the highest point of the iliac crest and a horizontal line midway. You aim for the upper outer quadrant.
Why there?
That area is primarily gluteus, medius, and minimus muscle bulk, and it's reliably superior and lateral to the typical path of the sciatic nerve, which runs more inferiorly and medially. Injecting here dramatically reduces the risk of hitting the nerve.
All right, let's tie this anatomy directly to clinical problems. The text highlights several common issues. Let's start with bursitis again, trochanteric bursitis.
Right. This is inflammation of that bursa we mentioned, the one lying over the greater trochanter, that bony bump on the side of your hip.
What causes the inflammation?
Usually repetitive friction. The IT band, or fibers of the gluteus maximus, rubbing back and forth over the trochanter during activities.
Like what kind of activities?
Things involving repeated hip abduction or movements where the IT band is under tension. The text mentions running, especially on bank surfaces or steep hills, or excessive stair climbing, particularly carrying weight. Even poor bike fit could contribute.
And the symptoms?
The classic symptom is a deep, aching, sometimes burning pain on the lateral side of the hip. It might radiate down the IT band towards the knee. But the key diagnostic sign is point tenderness. It hurts right when you press directly on the greater trochanter.
Okay, contrasting that with ischial bursitis.
This involves the bursa that cushions the ischial tuberosity, the sitting bone. It's often called weaver's bottom or cyclist's bottom historically.
So related to sitting and friction there.
Exactly. It's often due to prolonged sitting on hard surfaces or activities involving repetitive hip extension while seated, like rowing or, again, cycling, especially with an improper saddle or position causing friction over the tuberosity.
The text mentions a particular risk with chronic ischial bursitis in certain patients.
Yes. Because the ischial tuberosities bear so much weight during sitting, chronic inflammation and pressure, especially in people who are immobile, paralyzed, or generally debilitated, can be serious. It can lead to calcification within the bursa, and worse, the constant pressure can contribute to the development of pressure sores or ulcers over the area. Requires really careful attention to pressure relief.
Let's go back to the hamstrings. We know how they get injured, that violent eccentric contraction during deceleration.
Right. That mechanism makes them incredibly common injuries, especially in sports involving sprinting, jumping, hurdles, quick changes of direction. Football, soccer, track and field hamstring strains are unfortunately frequent.
Is one part more vulnerable than others?
Often is the long head of the biceps femoris, the lateral hamstring. Tears can range from minor fiber disruption to complete avulsions where the tendon pulls off the ischial tuberosity, and healing can be notoriously slow because it's hard to completely rest muscles that cross both the hip and knee.
Now, let's revisit nerve injuries. Damage to the superior gluteal nerve. What's the functional outcome we see?
That's the nerve supplying gluteus medius and minimus, the pelvic stabilizers. So if it's damaged, you lose that stabilization during the stance phase of walking,
Leading to
the Trendelenburg sign we discussed. When the person stands on the affected side, the opposite side of the pelvis drops noticeably. To compensate, they develop that characteristic Trendelenburg gait, lurching their upper body over the standing leg to maintain balance.
Okay. And then the big one, sciatic nerve injury, often linked to hip trauma.
Yes, particularly posterior hip dislocations or fracture dislocations. The nerve's proximity makes it highly susceptible to stretch, injury, or compression in those scenarios.
What are the consequences of severe sciatic injury?
They are profound. You typically lose function in the hamstring, so knee flexion is weakened. But the major deficit is distal. Paralysis of virtually all muscles in the leg and foot below the knee, meaning the patient can't lift their foot, dorsiflexion, leading to foot drop. They also lose the ability to plant R-flex, point the toes down, and move the foot inward or outward effectively. It's a massive functional impairment.
And sensory loss, too.
Yes, significant sensory loss over the posterolateral aspect of the lower leg and most of the foot, matching the distribution of the tibial and common fibular nerve components.
Finally, the text mentions piriformis syndrome. This isn't usually trauma-related.
Correct. Piriformis syndrome is thought to occur when the sciatic nerve gets irritated or compressed as it passes near, or sometimes through, the piriformis muscle itself.
What might cause that compression?
Things like spasm, tightness, or even hypertrophy enlargement of the piriformis muscle. This can happen from overuse, muscle imbalances, or sometimes those anatomical variations where the nerve actually pierces the muscle.
And the symptoms would mimic sciatica.
Exactly. Pain, tingling, numbness radiating down the back of the thigh, potentially into the lower leg and foot, closely resembling symptoms caused by a herniated disc pressing on the nerve root higher up. So it's an important condition to consider in the differential diagnosis of leg pain originating from the buttock. #tag outro.
Well, that wraps up a really detailed exploration, a deep dive into the gluteal and posterior thigh regions, covering a lot of ground.
We certainly did. We looked at those powerful superficial muscles, particularly the gluteus maximus and its specific role, and then the critical stabilizing function of the gluteus medius and minimus during gait.
And we untangled the complex actions of the hamstrings, primary hip extensors in walking, but critically acting as brakes during the swing phase, which explains their injury risk.
Plus, tracing the neurovasculature, anchoring everything to the piriformis muscle, and understanding the path and the clinical importance of the sciatic nerve was key. Not forgetting the vascular safety net provided by the cruciate anastomosis.
It really highlights how structure and function are so tightly linked. In our next deep dive, we'll continue our journey down the limb. We'll move distal to the knee to explore the diamond-shaped space at the back, the popliteal fossa, and then delve into the muscular compartments of the leg itself.
Looking forward to that. But before we go, maybe a final thought for you to ponder. We talked about the gluteus maximus being relatively quiet during normal forward walking. What if you had to walk backwards for a significant distance? Would the G-max become more important then? Think about the mechanics of pushing backwards against gravity. Does its role change?
Interesting question to consider. Thanks for listening to Bookfulness.